Atopic dermatitis is a triad of a condition that's made up of eczema, asthma, and seasonal allergies. Sometimes it can be also seasonal rhinitis, but it's the triad that makes it different. Atopic is atopy, means the allergies of the skin. Eczema is like this big category that people are like, can I catch that? Is it an allergy? Is it contagious? It's not. It's an inflammatory skin condition. There's different subsets of eczema, and atopic derm happens to be one of them. It's the itchy skin inflammatory disease that usually presents in childhood, early infancy. People come in and my child is just itching, very scratchy, but then you can look in their family history and see that they have either parent or family history has asthma or seasonal environmental allergies, or as an adult you have all three. So at that point it's pretty much medical history and physical exam that you start to look at.
Awesome. So from a primary care lens, your primary care physician, how should we first refer to you, dermatology, or should we refer to an allergist?
Dermatology.
Okay.
You're kind of me.
Okay.
So pretty much you want to go through, what does the patient do? Not everything is, let me just give you a steroid, let me just give you medication. Get some history in there. How do you take care of your skin? What products do you use? Do you drink enough water? What is your diet? Do you get enough sleep? It's a physical exam. It's history. Most people just at this point trying to throw medications at people, but you should educate your patients, especially those in our community are not educated on our skin at all. It used to be the role of the primary care to first do the skin, but I understand it's become over-encompassing with a lot of work, insurance companies. So that's what our job is for. We come in and I start asking people, so how do you bathe your child? First thing everybody wants is a baby that smells really good, but then the baby is itching and scratching in their bed. So you have to start thinking, let's take things away. I always tell my patient, eczema is the itch that rashes. What does that mean? It's what you pretty much present to your skin that you react to. It's a reactionary condition. Take away things. Your clothes would still smell good without lavender in them. Clean your body, clean your clothes, hydrate your skin. And those are the first steps you start taking for atopic dermatitis. So eczema is, like I said, just general term of inflammatory skin condition, but atopic derm is an itchy one. So then you have to go into history. So you present to me and I look, and especially with African American patients, more so than our European counterparts, we get more severe forms of atopic derm and we get it more often. Why? Because our skin is naturally drier. So what do? We look back into what are the products that we use? What is the most product that most people use? Used to be ivory soap, stuff like that. Thanks to COVID, now people know what CeraVe is, but you want something that hydrates the skin. CeraVe, Cetaphil, La Roche-Posay, things that add ceramide or fatty lipid levels to the skin, things that hydrate the skin. That's what you want to start using. And not everything is Axe, Old Spice, all those things that, and Dove is just remarkably cliched now. It used to be the soap that took away like fragrances. Now even the Dove for Men is a very fragrance product. Take away those products so that people can stop reacting to the skin. Then we start talking about the breakdown of matter of the skin barriers and the immune, like type 2 inflammatory reactions that come with atopic derm. So we have an immune system that's right at the level of the skin. We talk about T cells, H2 helper cells that you want to stop from going down the inflammatory road. So how do you stop that? You start taking away things. Filaggrin is pretty much the protein, it's the filamental protein that helps with the skin barrier protection. And sometimes that's lacking in people who have atopic dermatitis. So how do you build it back in? So that's how we've started to build in treatment modalities for atopic derm too, based on those different proteins and cytokines that are lacking in that type 2 inflammatory reaction of the skin. In residency, it's great to get out and go into different programs that have different populace of patients. If you just go in your residency and you only see a particular type of patient, when you go out into the real world, you wouldn't know what another patient presents as. I've had in my practice a lot of people come in with psoriasis, eczema, and they can't tell what they have because they're African American. We have more pigmentation to our skin. Derm is the one specialty where you present based off of your presentation is based off or differentiates based off of your skin tone. Instead of being a red inflammatory skin condition like atopic derm is in more white patients, we get more like purplish, browner, discolored, or ashen gray lesions. So it looks different to people. Like, what is that? Some people have scratched so much they look like they have burns. But it's atopic derm. It's still, you have to look and go, is it lichenified, meaning thickened skin? Is it in certain areas? Atopic derm has a presentation. Is it over the eyelids? Is it on the cheeks as baby? Antecubital, popliteal fossil. Those fissures and those locations are trademarked for atopic dermatitis. When you start to see that, you go, oh, you see Debbie Morgan lines, and most people have atopic derm because they're always trying to pretty much nick their nose and they break the cartilage. That's a sign of seasonal allergies or seasonal rhinitis. The rubbing of the eyes when you're waking up, all because of the itching of the seasonal allergies, is another sign, atopic dermatitis. You have to stop saying, okay, is it eczema? No, you have to go further with the history.